Chapter 17, Health, Population, and the Environment. This chapter covers a number of modules. We are going to focus on health, health in the United States, social epidemiology, and population. In our look ahead, we will define, what defines a healthy environment. We will ask that question. How is the environment connected to our health as a society? And how do health and healthcare vary from one social class to another, even from one nation to another? Okay, so our first module are sociological perspectives on health and illness. The first thing I want to talk about before we get to the definition of health is culture and how it relates to health. Where a person lives has an effect on their health. People who live in the city, they may experience stressful, congested, polluted environment, yet hospitals and doctors are plentiful. Suburbanites experience less congested environments. Their business and homes may be more spread out. And then rural areas, where there are wide open spaces, they might have to travel pretty far to seek medical care. So there are definitely some cultural influences in healthcare, in that it influences the definition of health, the types of care available in a given society, access to care, and the incidence of disease. Certain diseases or disorders are often attributed to specific cultures. Your book describes the high incidence of, say, depression and alcoholism among Navajo Indians. The research was conducted by Dr. Lori Alvord, who writes that even African Americans are at high risk of these things as well. Now, a disease that cannot be understood without the specific social context is called a cultural bound syndrome. One example is anorexia nervosa, and it's considered a culture-bound syndrome in the United States. This disease is best understood in the context of the U.S., where a culture of being thin is emphasized as being beautiful and healthy. So many people are bound and trying to achieve that level of weight loss. Medical practitioners are being trained to recognize these, different cultural beliefs that are related to medicine. The World Health Organization in 1946 defined health as a state of complete physical, mental, and social well-being, and not merely the absence of disease and infirmity. Being defined in this way, it helps to think of health on a continuum. Healthy status being at one end and death and dying being at the other. People's definitions of where they are on this continuum varies according to different situations and or culture. Now, it is socially constructed. We say health is and illness are socially constructed because health is relative. We can view it in this social context. Individuals define themselves as either being healthy or sick based on various criteria. And in this current environment that we are in today with the pandemic, coronavirus, COVID-19, we're learning what those criteria are. You have to meet certain criteria before you could enter, a restaurant or a doctor's office or a building, take your temperature, asking a series of questions. So it's important to consider how these different situations, even being in a different culture, and how health varies. So we're going to use our four sociological perspectives: functionalism, conflict theory, interactionist theory, and labeling theory, to examine this definition of health and treatment of disease. And the first theoretical perspective is the functionalist approach. According to this perspective, being sick must be controlled so not too many people are released from their societal responsibilities at the same time. Being sick is considered a dysfunction that disrupts social stability. When we are sick, we take on a certain role. This sick role is society's expectations about the attitudes and behavior of a person viewed as being ill. Now, sociologist and functionalist Talcott Parsons has said that people who are sick are excused from their everyday duties and are not blamed for their condition. However, the sick person is obligated to get well, which is important, particularly when workers are critical to society. We have that term for them today called essential employees. Now, according to Parsons, physicians function as what he calls gatekeepers for the sick role. They verify, they verify the illness and they help the individual to recover. Now, critics of the functionalist view argue that patients' judgments about their own health may be related to things like our gender, age, social class, and ethnicity. So here we have the critics, and the sick role may be more applicable to people who are experiencing short-term illness than to those with recurring long-term illnesses. So even simple factors seem to affect one's willingness to assume that sick role, as does, say, the impact of socialization into a particular occupation or activity. So, for example, what does this all mean? Young people may ignore serious warning signs of illness or injury, while older people may focus on it too much, even. Women are more likely to seek care than men. So critics, again, say that the sick role may apply more to people with short-term illnesses than long-term, and that various factors like employment affect a person's willingness to assume that sick role. I know many women who are working and have children that they may go to work sick because they have to in order to bring home that paycheck to provide for their families. Now, sociologist Elliot Friedson argues that medicine has an officially approved monopoly to define health and to treat illness. So this is the conflict perspective. And conflict theorists say that, there's that medical profession has this approved monopoly, what is defined as health and illness and how to treat that illness. The medicalization of society, according to conflict theorists, refers to the growing role of medicine as a major institution of social control. Medicine maintains social control two ways. First, by greatly expanding the domain of expertise. We expect that the physicians, are the experts, and not only on infectious diseases, but other problems like sexuality, old age, anxiety, obesity, child development, alcoholism, and drug addiction. These problems are increasingly viewed using a medical model. And when medical experts influence the proposal and decision-making regarding these issues, often emphasizing the physical or medical factors as compared to the social, cultural, or psychological factors. A second way medicine maintains social control is by retaining jurisdiction over healthcare, placing certain healthcare professionals, such as chiropractors or nurse midwives, outside of what is considered acceptable medicine. Conflict theorists also examine the obvious inequities that exist in healthcare, like how in the U.S. poor areas are underserved because medical services are concentrated in areas where people are wealthy. Globally, inequities exist as well. For example, in the U.S., there are 25 physicians per 10,000 population, compared to fewer than 1 per 10,000 in African nations. This situation is worsened by what is known as the brain drain, and this is the immigration to the U.S. and other industrialized nations by skilled workers, professionals, and technicians. Doctors, nurses, and other healthcare workers leave developing countries to come to industrialized nations. The brain drain is a way that core nations enhance the quality of life at the expense of developing nations. A leading indicator of how well a nation or society is doing is based on that country's infant mortality rate. This rate reflects the level of health services based on the wealth or poverty of the nations. Dramatic differences in this infant mortality rate around the world indicates an unequal distribution of healthcare resources, including things like prenatal care, nutrition, delivery procedures, and infant screening measures. The infant mortality rate equals the number of deaths of infants under 1 year old per 1,000 live births in a given year. And so that rate is examined and looked at to see how the health status of a particular nation. And here we see infant mortality rates in selected countries, and you can see it's very small, but 5.8 is the figure for the United States. And you see poor nations like Central African Republic, Pakistan, Afghanistan. These poor nations have higher than average infant mortality rates. So the world is that green shaded bar in the middle. So it's above what the world's rate is, and then below. Now, the interactionist approach is a micro-level approach, and it studies the roles played by both healthcare providers and by patients. Now, patients are not passive participants. Often, they seek healthcare services, and some actually play an active role by failing to follow the doctor's advice. They stop taking their medicine, they take the incorrect dose, or any other kind of non-compliance. Some actively will go out and search and read and learn about preventative measures in order to remain healthy. And physicians also take on their occupational role. They put that white lab coat on. They might speak, more in the medical terminology. The layperson has a hard time showing that they have this sort of expertise. Now, this labeling perspective, when we think about society's definitions of healthy or ill, this results in the attaching of labels and therefore leads to consequences. Labels associated with illness shape how others treat us and how we see ourselves. Labels suggesting less than perfect physical or mental health result in serious consequences. We can view a variety of life experiences either as illness or not as illness. For example, we have things like premenstrual syndrome, post-traumatic stress, attention deficit hyperactivity disorder. These have all been labeled medically recognized disorders. Things, chronic fatigue syndrome is still under debate. Restless leg syndrome, sensory integration disorder. These are all, coming up to be discussed. Are they disorders or not? Homosexuality was once labeled as a mental disorder. But in 1974, after protests from gay and lesbian rights members, the American Psychiatric Association voted to have it removed from the DSM, the Diagnostic and Statistical Manual of Mental Disorders. Now, what you should come away with after this module is that health and illness are more than just biologic, physical occurrences. Social factors, our culture, family and friends, the medical profession also impact an individual's well-being, and that the delivery of health care is very much a societal issue. So here again we have, in this table, the theoretical perspectives and how we view health and healthcare delivery. This module, we're going to talk a little bit about social epidemiology. Social epidemiology is the study of the distribution of disease, impairment, and general health status across a population. Contemporary social epidemiology is not only concerned with epidemics, but also with non-epidemic diseases like injuries, drug addiction, alcoholism, suicide, and mental illness. They're also even tracking bioterrorism, and as we hear from the news every day, the study of the pandemic, the coronavirus. So every day we get reports and statistics and numbers about the number of people who have tested positive, the number of deaths, and so we're seeing this across, a pandemic. Epidemiologists use two concepts, incidence and prevalence. Incidence is the number of new cases of a specific disorder occurring within a given population during a stated period of time. Usually it's a year. Now with the current coronavirus, COVID-19, we're getting daily reports. So, how many cases were reported, new cases reported in that specific time period. Prevalence is the number of cases of a specific disorder that exists at a particular point in time. So from the start of the coronavirus pandemic, and how many up to this date, to a specific date. Or if we're talking about something like, I have data on the prevalence of HIV/AIDS in the U.S. through 2009, for example. It was about 1 million cases. So that was all the cases up until that point. Now, when disease incidence figures are presented as rates, or the number of reports per 100,000 people, they're called morbidity rates. And often, too, you'll hear reports in the discussion of coronavirus and the COVID-19, these morbidity rates or comorbidity rates. So in addition, if a person has tested positive for COVID-19, what other comorbid conditions might they have? Heart disease, diabetes, and things like that. Morbidity rates per 100,000 helps us to see what a specific disease, that specific disease occurs more frequently in one segment of the population than another. And so that's why we can see, is this happening more frequently in the minority population, young people versus old people. And so that's another thing they're tracking, those morbidity rates. Now, a mortality rate is something different. A mortality rate are the incidence of death in a given population, or the rate of death. Here we have a table, again, showing as an example AIDS by the numbers worldwide, what they were in 2001 and then up to through 2016, the new infections, the number of deaths, and the people accessing treatment. Treatment began about 2007. Now, morbidity rates are affected by social class, race, ethnicity, gender, and age. So we're going to take a look at these different variables. First, let's consider social class. Lower classes tend to have higher rates of disability and mortality. Crowded living conditions, substandard housing, financial difficulties, poor diet, higher stress levels, and the inability to afford quality health care are major factors in the health problems of the lower classes. Social class appears to have a cumulative effect. When you don't have access to health care as a child, you tend to have more illness as an adult. The poor are less able to afford quality medical care. Upper classes are more likely to afford medical or have a job that provides that health insurance. In 2009, as we entered the recession, more people were going without care and medications. Nearly 51 million people. Healthcare reform was enacted in 2010. This is known as the Obamacare, and the Obama administration put forth this act, the Patient Protection Affordable Care Act. Immediate help was given to high-risk individuals. By 2014, people who were sick, who've lost their job, were able to access health care. This all began in October of 2013. Now, all things considered, there are more dangers in lower class workplaces than in middle and upper classes. So conflict theorists therefore argue that maximizing profits is more important to capitalists than their workers' safety. So it's a vicious cycle of low income leads to poor health, which prevents upward mobility. And here we have a map of the United States that shows the percentage of people without health insurance, the uninsured rates. And the blue shaded states, if you see, are 10% or more uninsured in that state. The U.S. rate is 8.6%, so those states shaded in blue are higher than the rate of U.S. as a whole. And I just wanted to, point out Florida, Texas, North Carolina, and those are states right now that are showing high cases, hospitalizations of people with COVID. So if we have a lot of uninsured there as well. The only exception, I believe, is California. Health profiles of racial and ethnic groups reflect social inequality in the U.S. Poor economic and environmental conditions manifest in high morbidity and mortality rates among African Americans, Hispanics, and Native Americans. African Americans die from heart disease, pneumonia, diabetes, and cancer at higher rates than whites, and their death rate from stroke is 2 times as high. If we look at life expectancy, African Americans can expect to live to 71.7 years, compared to whites, which is 74.7 years. Infant mortality as well is more than 2 times as high among African Americans as compared to whites. National clinic studies show that racial and ethnic minorities are less likely than other groups to receive standard health care and life-saving treatments for a variety of conditions, including, one example is HIV. According to sociologist Howard Watskin in 1986, African Americans suffer the stress of racial prejudice, leading to hypertension, which is twice as common in blacks as whites, and is a factor in high mortality rates from heart disease, kidney disease, and stroke. Some Mexican Americans use a form of holistic health or healing known as curanderismo. Sorry, apologize that. These are folk heroes that rely on home remedies to treat the population, yet they're more likely to seek, some Mexican Americans are more likely to seek treatment at clinics or ERs for medical problems than to get regular preventative care with a family physician. Now let's talk about gender differences. Women experience higher prevalence of illness compared to men. However, they tend to live longer. Women's experience lower rates of cigarette smoking, alcohol consumption, and lower rates of employment in dangerous occupations. These rates may explain a third of why they may live longer than men. Some studies suggest that differences in morbidity is not so great because women tend to seek treatment, be diagnosed, and therefore be included in research findings. Conflict theorists report that women are more vulnerable to the medicalization of society in terms of giving childbirth and any beauty treatments that they may receive, which are becoming increasingly performed in a medical setting. Older people in the U.S. have at least one chronic illness. Older people are troubled with conditions that affect quality of life and daily living. For example, almost half have arthritis. We're dealing with arthritis. Visual and hearing impairments are also an issue that many have. And again, they're especially vulnerable to mental health problems. Older people are vulnerable to certain types of health problems, particular The leading cause of dementia is Alzheimer's, and this affects an estimated 5 million older people, age 65 or older. That's a third of the population. Older people disproportionately use the healthcare system compared to younger people. Those 75 and older are 5 times more likely to use health services and to be hospitalized than younger people aged 15 to 74. And this is data from the Census Bureau. Healthcare use for older Americans is critical in the discussion about healthcare costs and reforms of the healthcare system. In addition to considering age, social class, race and ethnicity, and gender, in their effort to achieve greater healthcare access and reduce healthcare inequalities, federal officials must also take into account the geography of healthcare resources, physicians, hospitals, nursing homes, medical daycares, how many, where are they located, and is there access to this care? Now, there's been little recognition that people seeking healthcare may be lesbian or gay. Historically, LGBT people and their families have encountered intolerance in the healthcare system. And there's really limited research to date on particular wellness issues. One study found child development goals that are not impacted by parents, whether there be transgender parents in this particular study, lower levels of self-reported health among LGBT individuals. So there needs to be research. Research is needed on delivery of mental health services as well. Next, I'd like to talk about healthcare in the U.S. Healthcare costs are 4 times what they were in 1980. In the year 2000, the amount spent on healthcare equaled the amount spent on education, defense, prisons, farm subsidies, food stamps, and foreign aid combined. Medical care costs continue to rise. Bills often run in the tens of thousands of dollars. Healthcare is big business. So we need to think about, this and keep in mind, what is the impact that the coronavirus and COVID-19 may be having on the healthcare system. We hear talk of a shortage in ventilators, a shortage in PPE, protective equipment, and so that can tell runs into a lot of financial issues. So again, in the total, when you're looking at these numbers, the total healthcare expenditures, again, what is even projected into 2025 is going to be very different when we factor in this year and moving forward, and how long this is going to take to account for the coronavirus and COVID-19, and the rehabilitation industry is going to be impacted as these patients recover and need continued health care and general health equipment. Healthcare at one time in the U.S. Was characterized by self-help, prevention, a variety of approaches and practices, and types of practitioners. It was known as the popular health movement of the 1830s and 1840s. The emphasis was on, again, preventative care and self-help. The American Medical Association, or the AMA, was founded in 1848. And this AMA set up standardized training and licensure and gave professional authority to those who complete their programs. As a result, doctors gained significant control over the market for medical services and the various institutions that govern medical practice, financing, and policy. By the 1920s, physician-controlled hospitals division of labor of health personnel, and had indirectly controlled related professions such as nursing and pharmacy. Although patients have relied on medical personnel regarding healthcare issues, more and more patients are getting healthcare messages from the media, such as advertising and information from the internet. And there are problems in this amount of inaccurate information that is out there and incomplete information. Physicians are the dominant professionals in healthcare in the U.S. We're going to take a look at, from a functionalist perspective. According to functionalists, established physicians and medical school professors serve as mentors or role models. The role models transmit whatever knowledge, skills, and values they have to the learner and passive learner. Now, interactionists emphasize that students are molded by the medical school environment. They interact with classmates, and they learn and continue to learn through each other. Medical schools emphasize technical and clinical skill, dehumanizing the doctor-patient relationship. Publicity about malpractice suits and higher medical costs further strained the relationship between doctor and patient. Nurses are expected to remain subordinate in their interactions with doctors. And gender appears to contribute to the physician-nurse relationship, and studies show that female physicians traditionally have lower status than their male counterparts. As more females enter the medical profession, we may see a shift away from this dehumanizing approach to medicine due to a very expressive role in the profession. Now, 1 in 3 adults in the U.S. use alternative healthcare methods. When non-mainstream practices are combined with conventional medicine, it's considered complementary. If a non-mainstream practice is used in a place of conventional medicine, is considered alternative. Now, holistic medicine are therapies in which the practitioner considers the physical, mental, emotional, and spiritual characteristics of the patient. Treatments include massage, chiropractic medicine, acupuncture, herbs, nutrition, visualization, and exercise. So here are the traditional methods of healthcare: chiropractic medicine, acupuncture, respiratory exercises, and the use of herbs as remedies. Some practitioners have actual medical degrees. Some medical doctors include the alternative medicine in their practice, but acceptance by the medical establishment has been slow. 80% of the people who live in the poorest countries use some form of alternative medicine. Now we'll get some background on the governments and the history of healthcare. Healthcare did not receive federal aid until the 20th century. The 1946 Hill-Burton Act provided the first subsidies for building and improving hospitals, mainly in rural areas. In 1965, the enactment of Medicare, we have the enactment of Medicare and Medicaid. Now, Medicare is the compulsory health care for the elderly, while Medicaid is the non-contribution funding federal and state insurance plans that are put in place for the poor. And these had huge effects on the healthcare system. These programs greatly expanded federal involvement in healthcare financing. In 1983, the government put in place a cost control program to offset the increased Medicare costs due to high rates of illness and disability among the elderly. Any hospital that received Medicare funding could not dump patients, and dumping still occurs today However, in places like call Skid Row, where patients are just simply discharged from the hospital without any place to go. The expansion of health insurance, we had in 2010, the Affordable Care Act. This improved health insurance coverage for people of all ages, and it raised hope of improved health care. Upheld by the Supreme Court. Some provisions have been very popular, and critics say, however, that it can be very costly for taxpayers. And there's debate today in the political arena. We hear the current administration talking about repeal, making changes to this healthcare. Now, again, with this pandemic, it really needs to be thought out what the impact would be if that were to happen. Also, within this this chapter in this discussion, you want to consider population, because sociologists focus on the social factors that influence population rates and trends. These are some things sociologists would look at: trends in fertility, trends in mortality. We already defined what mortality is, and even migration, people who move into an area. Fertility is defined as the level of reproduction in a society. Mortality, as to remind you, is the death rate per number of population. And then the study of the scientific study of population is known as demography. So it's an entire field. Components of population size, composition, territorial distribution are things that are examined. A demographer tries to understand the consequences of population change. In studying the population today, some of the things we look at, for example, are, approximately 6 million children die annually in developing countries. And, by studying this, we know that we can find out that malnutrition accounts for 45% of these deaths. So again, it gives us information to act upon. This is a census year, and the census is an enumeration or counting of a population. Our U.S. Constitution requires that the census be held every 10 years. So we are in 2020 in the decennial census year, and I started in April. They started sending out surveys and counting the population. Vital statistics are also something that we use to study the population. Records of births, deaths, marriages, and divorces that are gathered through a registration system maintained by government units. And again, we're seeing statistics, almost daily now with this pandemic we are in. And the last thing I wanted to mention in this chapter is human ecology and the importance of studying these interrelationships between people and the environment. So that is human ecology. It's the study of these interrelationships. Everything is connected to everything else. And, we need to think about, how one thing might affect another. Global population growth has had a huge impact on the environment. So we need to consider both, but vice versa, and also how the environment affects the global population. One of the maps, if you've seen, I don't know if you picked up on in the beginning of this pandemic, they were showing overhead maps of the environment and what it looked like when, different populations were on quarantine and social isolating. It really showed an impact on pollution and the environment. And so again, we see one thing interacts and connects to another. So again, another important component within health and sociology and the different relationships that we consider and we study.